So welcome everyone. I'm Katie Buck. I'm the current president of AGEM, and it is my pleasure to welcome you all tonight to our Careers in Geriatric EM webinar. This is, I believe, the third time we've done this, and each time we've focused on a different sort of stage in the career. And tonight we're really going to focus on that early part with residents, medical students, and fellows. And with that, we are so excited to have RAMS co-sponsor with us tonight. We're going to go quickly. What is geriatric emergency medicine in case you're not familiar, what a career could look like, how the RAMS roadmap might be helpful, and then we're going to jump into our wonderful panel. So why geriatric EM? Why do we all get so excited about it? Back in 2011, about 15% of EM visits in the US were geriatric patients, and the estimates are that'll be about 33% by 2030. Hard to believe it, but we're actually going to be there before we know it, and then we'll get even new predictions. As many of us have seen from our clinical shifts or rotations, compared to younger adults, older adults have longer lengths of stay. They require more testing. They have higher rates of complications and functional decline. All of this leads to atypical presentations. They're often taking more medications. They'll respond differently to the medications that we give them while they're in the emergency department. And they have geriatric syndromes that might complicate or add to their presentations. But with all of that and all the challenges that they present, they are a very grateful patient population and can be very rewarding to take care of. And so with all of that in mind, the question I would sort of pose to you is that most of us have loved ones that are older and hope one day ourselves to be older. So how would you want yourself to be treated or your family member? And that is what drives what we do, constantly trying to make that patient experience and patient care higher quality. So what kind of careers are there within geriatric emergency medicine? Well, it's really exciting. So the sky is truly the limit, and it's expanding all the time. The typical pathways that I'll talk about now are not the same as they were 10 years ago and will not be the same in 10 years. But right now, the typical pathways that we think about are a research career, clinical, which can include at the policy level, or running a geriatric emergency department. And then the guidelines that guide that clinical care, which you'll hear about, I suspect, from Dr. Liu later. There's also education, so teaching the medical students, residents, and fellows. And then there's also a lot of leadership opportunity within geriatric emergency medicine and leadership development. So how do you get started? By either tuning in tonight or watching online later, you've already gotten off to a great start. You can do things like join AGEM or one of our committees and really see what we're doing and what we're all about. And then come join us at SAEM 25. All of these events are open and we'd love to see you. Our, of course, business meeting will be on Wednesday, and then we have our networking dinner on Wednesday evening. And we really do love when the medical students and residents come and we get to know you. And then we'll also have a JEDC dinner again on Tuesday. So make sure you watch for all of those events when you're registering for SAEM. For even more detailed information, because we're not going to go through all of it tonight, make sure that you check out the RAMS roadmap. There is one for geriatric emergency medicine, and it is set up to take you through each step of your career and training and sort of give you tidbits for what you can do at that point and what might be coming next. So for example, if you looked at the fellow page, you would see that there's actually geriatric emergency medicine fellowships. They can range in how long they are. Some of them come with an advanced degree. And then you can also do other fellowships, such as research or admin, and you can apply that to geriatric emergency medicine. All right, enough of my talking. It's time to jump into the panel. Our wonderful moderator for the panel is going to be Surya Ahmad, and she completed her EM/IM residency at SUNY Downstate in Kings County. After residency, she actually did one of those geriatrics fellowships at Cornell and New York Presbyterian. And she has been involved in AGEM for a very long time, and I believe has been involved in all three of these webinars. So she's an expert in this area, and she currently serves as our AGEM secretary. We're first going to go through some pre-selected questions. Then if there were questions at registration, she'll take us through those, and then we will open it up in case there's any live questions that you think of. And I will introduce our panelists, and then we will turn it over. So our first one is Dr. Shan Liu. She is an associate professor of emergency medicine at Harvard Medical School and the director of their geriatric emergency medicine fellowship. Among her many roles and accomplishments, she's a former AGEM executive committee member, including president, and she currently co-leads the ongoing and large project to update the geriatric emergency department guidelines. Our second panelist tonight is Dr. Manish Shah. He is professor and chair at the University of Wisconsin. He helped establish the field of geriatric emergency medicine and was recognized as one of the 4 pioneers of geriatric emergency medicine at our 10th anniversary a few years ago. He's had a standout research career, including funding from the NIH, AHRQ, and CDC, just to name a few. And he has served and currently serves as a mentor to many within AGEM, is also a former AGEM president, and is the immediate past president of SAEMF. And last but not least, Dr. Rachel Skanes is an assistant professor at the University of Alabama at Birmingham. She also has a joint appointment at the Birmingham VA Medical Center. She completed a clinical research fellowship and a T32 postdoctoral scholar fellowship. She's currently one of our amazing AGEM RO3 GEMSTAR scholars. She is the ED physician champion for several accredited EDs and currently serves as the AGEM Executive Committee member at large. So I'm very excited to hear from all of you. And with that, Saria, I'm going to hand it over.
Hi, everyone. Thank you so much for joining. Thank you so much, Katie. Thanks for the 3 panelists. We're going to start with just some general questions that are for all 3 and anyone answer at any time. The first question, we're just going to learn a little bit about why geriatric emergency medicine from each of your points of view, what draws you to the field, like most about the field, and in general, when you first felt drawn to the field, what about it first inspired you?
So I first started my interest in geriatric emergency medicine. I had just finished after residency a doctorate in public health doing research on adverse events and boarding. And someone mentioned, focusing on geriatrics because there was a GEMSTAR opportunity. And I realized that, among the people who are boarding and dealing with crowding issues in the ED, that the geriatric population are the most vulnerable patients. And I also am a fan of Eula. I was like basically following her career and basically saw that she was doing sort of similar work, which was pain management, crowding, and then geriatrics, and really ended up following her into geriatric emergency medicine. And literally Kevin Bice at one of the SAEM meetings said, you should come to an AGEM meeting. It's a group of really awesome, kind, it's a tight-knit group. And so I went to the AGEM meeting, and I suppose the rest is history. And I really have been drawn to the field because I haven't met anyone in the field that isn't, really overall kind and generous with their time and generally always trying to do the right thing. And I also really love that it's multidisciplinary and that it's one of the few specialties that really sticks to take care of the whole patient. So not just the heart or not just the lungs or the abdomen, but really wants to take care of the entire person. So that's why I've stayed with geriatric emergency medicine this whole time.
All right, I'll go next since I guess we're going alphabetical. So, I wish I had some profound story to tell, but the reality was when I was a research fellow in 1999, my mentors told me to go find something that needed impactful research and something I'd want to fix, and that also had an NIH institute because you're more likely to get funded. And after reading Lowell Gerson's work and talking with my mentors, geriatric emergency medicine became pretty much the no-brainer answer because other than Lowell and Art, there was pretty much nobody doing research in the area. And because I wanted to do EMS research, which nobody funded, and because I was interested in what we now call community paramedicine, this is how we thought we could pull it together and make NIH pay for it. I think the big reason why I stuck with this, other than the fact now I am old and now I actually really do care about this because it affects me, is that the group is a great group. Lowell and Art and the early people in the group, it was really very much an open group. We shared everything, we supported everyone, and we really helped each other become leaders in the research sphere. And so that culture has continued, which is just really awesome because anyone can call me, I can call anyone, and it's always just a free communication and no one's trying to hide and protect and whatnot. And I think that's actually just best for the specialty and it's really best for our patients.
All right, I'll go next. Mine started actually in undergrad. I was a neuroscience major, and at the time, at the end of college, I was really struggling with whether or not I wanted to go the PhD route or the MD route. And so I actually got off of pre-med and really focused on neuroscience research and bench research and did 2 years before going to medical school doing lab bench research and clinical research at a neurology department at Carolinas in Charlotte. And during that experience, most of the neurology syndromes that we were studying at the time were ALS and MS. So it was an older patient population. And through a lot of the mentors that I met during those 2 years, I really realized that I didn't have to choose research or medicine, that a lot of MDs also do research. And I didn't realize how widespread that was. So when I went to medical school and really fell in love with emergency medicine, I really wanted to be connected still with that patient population and in neuroscience. Thought about a lot of different types of fellowships that I wanted to do, whether that be neurocritical care or palliative medicine or research, and really landed that geriatric emergency medicine, like Sean was saying, encompasses so much that I can explore all those interests that I had and feel pigeonholed into one thing, like I did when I was seeing the bench research of people focusing on like this small segment of a protein for their entire career. That if I wanted to do a medication safety or cognitive impairment or collaborate with different departments, whether that be neurology or EMS or geriatrics, that was available in the space of geriatric emergency medicine and those collaborations. And like Sean was saying, the collaborators and the people in this space are just so generous and so amazing to work with, very different than anyone else that I've ever met, very welcoming and supportive. And so I really stayed in this space, but it's really just a love for older adults in all aspect of their care.
Well, thanks for sharing. The next question's kind of similar to some of what you've all touched on a little bit. It was, what has the training looked like to get to where you are? And then what does your career look like day to day now? So whichever part of the questions that you didn't get to or want to elaborate more on, we can hear a little bit more about that.
So probably like a lot of people, at least, my colleagues on the panel, like, I don't think I didn't personally set out when I first wanted to go to medical school to end up doing geriatric emergency medicine, because it largely didn't exist until leaders like Dr. Shaw and Dr. Gerson and others started it. So it wasn't something that I encountered at all during residency. So I think as it has grown, those opportunities to be involved have just really grown. And so you hear much more about it. There are a lot more books and a lot more webinars and a lot more organizations. And so a lot more mentors that are, inviting mentees to look at this kind of career. And, I don't know how long it's been since there was geriatric ED, probably the last 5 or 8 years or so. And so I think that has fueled a lot of interest of people who are graduating to say, oh, I can have a career in this, because you're going to only increase in terms of need for people who are interested in this field. So to answer your question about training, I ended up doing residency in emergency medicine, and then really enjoyed public health. And so ended up doing 6 years after residency. I worked half-time and was doing research on adverse events among people who are boarding. And then I fixed that problem. So I decided to fix geriatrics, emergency medicine. No, just kidding. Obviously kidding. But I look at that time as being amazing, because my dissertation mentors said, you have to take these classes. And I kind of whined about it. I don't want to take qualitative classes. But what they were trying to do is set me up for a career where I had a toolbox where I could use different things and tools to answer certain questions, depending if I had funding or not. So it was great to be forced to take qualitative studies, qualitative classes. It was great to take health services research classes, and then just a whole smattering of classes. So I look back on, I don't think everyone has to do that as a pathway, but I really nerded out. I loved being in school. I loved taking classes, and emergency medicine in our career, we lended itself to doing that because I could work part-time, and then I could use the research I was doing in school, to publish as a faculty member. So I got to take classes in economics, and I thought it was just fascinating. So I look back, even though that was a long journey, now I feel much more confident being able to answer a bunch of different questions, and not necessarily, specializing just in economics or just in clinical effectiveness and things like that. But I'll say I spent a long time after grad school applying for federal funding. I think I met Manish at one of these SAEM grant things maybe 12 years ago, and he's like, you should apply. And I was like, oh. And so I spent 10 years applying for GemStars and other things, and really got a lot of rejections. I tried talking to the program officers. I tried really changing my projects. I ended up doing sarcopenia, and could you measure that on ultrasound in the ED? Tried to do like a falls app, and really tried to get it funded, and basically just couldn't really get the project funded with the GemStar. And I think at one point my mentor was like, you've really tried. And at that time it was during COVID, and I ended up for various reasons, writing this children's book about my great-grandfather who invented the forerunner of the N95 mask. And I told my mentor, and he just saw me light up about it. I was like super excited about it. And I said, I just really feel like I want to do this and really share this story. And he looked at me and he's like, you have never, exhibited this kind of excitement about your research for your federal grants. He's like, I think you should really follow your passion. And if your North Star is really, trying to make an impact, trying to do this and that, it's okay if you want to let go of applying for federal grants. And that has been a relief because my mentor basically said, I don't think you really had your heart in doing sarcopenia research using ultrasound. And he was totally right. And I think I had just really spent a lot of time trying to make it work for the federal government. And that isn't really what they wanted to fund. And that's okay. I mean, I am in awe of people like Manish and Rachel and many others in our AGEM group who are super successful and are able to get their grants funded. And I'm just give them total respect. But I'm here to tell you that you can have a great career in geriatric emergency medicine and find other ways to do it. So the fact that I was able to, I do still apply for grants every year. They're just smaller grants, but that opened me up to actually really digging deep about what I really wanted to do with my time. And so I walked in and ended up doing the geriatric ED guidelines. And thanks to Eula Wong and John A. Hartford and West Health, I was able to get some funding to spend doing that. And since that time, since my mentor was like, I think you should really figure out what you want to do and what your passion is, my productivity has been much, it has really exploded because I was doing what I was really aligned. I was aligning my passion, my interest in research and work with what I was doing with my time. And so I think as young people, just getting your career started, I really think it's important to pause and say, is this really what I want to do, what I want to spend my time on? And if it's, the world will tell you if you're misaligned, if you're not aligning your values and your interests with how you're spending your time. So that's my way of saying that I failed at getting federal grants, but it allowed me to open the doors and walk through other doors that have made me much more satisfied with my career.
Yeah, I'm actually going to build on that because I think that's probably one of the most important points is what do you really want to do, at least for now? I think for me, it was research. I knew I loved research. I did a research fellowship, and that's the way I was going. But ultimately, it was actually about how do I make an impact in everything we're doing in terms of taking care of our patients, in terms of developing the next generations of researchers and leaders. And I think that's why our careers evolve over time. That's why we can change direction slightly. And so, a couple of years ago, when I applied to be chair and ended up becoming chair, I knew that was going to reduce the amount of research I could do. There's only so much time in the week to do research, and I get pulled into lots of administrative stuff now. But on the other hand, the cool thing, I can ensure that we support geriatric EM research, whether it's here in Wisconsin or whether it's nationally. I can advocate for it as a chair. And more than that, I can mentor a whole bunch of people and help them get to that next step, which for me at least, is really the natural next step of what I do in my career. There's a number of us now that got the GemStar, or back that was called the Janigan, and got a Beeson, or some others have a K award, and got ours, who are now either chairs or vice chairs or other leadership roles. That's one way to do it, but there's so many other things that are needed, whether it's on the educational side. Tess Hogan's been doing great stuff with that, and others have been as well. The beauty in our group is that we're diverse in terms of our interests, and it takes all of us to really advance this field. I think probably my argument would be that if you want to do the research side, which I'm going to focus on, you need to do that fellowship. You need to have some sort of advanced research training. You need to have probably an advanced degree of some sort. And you need to find the mentor, find this place that you can go to really do the research you want to do, and just keep developing yourself and go through kind of the hoops that exist for you to be able to do that research that makes a difference for you. But if you're not interested in that as much, there's lots of other ways, whether it's doing a geriatric emergency medicine fellowship and just driving the clinical care through clinical operations, or whether it is driving the educational side of things. And so, my career has wandered around with a fair amount of EMS operations, and now, just being on the chair side of things, but it's okay for that to evolve as well.
So I think we've heard kind of middle career and then more, later stage advanced careers. And I'm going to talk about the beginning of your career because I feel I am early stage. And so I think that I'm probably closest related to maybe a lot of the med students and residents that are on the call in terms of what you're thinking about in preparation for a possible fellowship. And so for me, I knew during residency from the very beginning that I wanted to do academic and I wanted to do a fellowship. And it's really trying to narrow down exactly what fellowship to do. And the great thing about geriatric EM, I think, as we've mentioned, is that there's a lot of different pathways to get to the same endpoint. And for me, that was a clinical research fellowship. I was the first one. I was the trailblazer at UAB to do one. So it wasn't an ACGME accredited. I applied to a T30 fellowship that was not in my department. So it was an internal medicine department and health services outcomes effectiveness research. And that allowed me to apply health services outcomes and effectiveness research to geriatric emergency medicine specifically. And I got an advanced degree in MSPH in clinical and translational science research. But that time and the buy down of that time to devote to a postdoc fellowship and have a reduced clinical load allowed me really to explore a lot of different things during that time and establish the infrastructure that I needed to be successful at my institution, which took several years. So the networking, the mentoring, meeting the informatics people, the EHR people, the quality improvement people, and really networking and building relationships on all these interdisciplinary departments to be successful. And I think that although a lot of us have talked about maybe more on the research side, I think it is important that as the only one at my institution doing geriatric emergency medicine research, I do education and service related things as well. So I'm the ED physician champion at UAB, but also the Birmingham VA. So I do a lot of quality improvement projects, a lot of operations projects with our geriatric level 1 accredited ED. I've brought a lot of quality improvement initiatives to both of those institutions. And then I do a lot of education with the residents and the medical students. So I've created a geriatric EM curriculum with the help of a lot of my colleagues, most of which are on this call, because we're a very collaborative group. They've shared a lot of their materials with me to be successful in that realm as well. And then really just, and we can talk about this, I think, in the next question, but digging in at the resources that you have at your institution. So leaning in on our Clinical and Translational Science Institute, so our CCTS, taking a lot of grant writing courses through them, specific AIMS workshops, and then really it's just networking nationwide. So joining AGEM, joining GEMS, joining those groups that you're interested in, meeting people. And like I said, I'm the only one geriatric EM at UAB. So all of my mentors are either not at UAB or in other departments. And I think that interdisciplinary work is really important these days. And so I'm still early stage. I've had several internal grants, pilot fundings. I have a GEMSTAR and I applied for a K-23, which will be reviewed next Tuesday. So we'll see how that goes. But yeah.
Great. Thank you guys so much. It's so wonderful to see the different varied backgrounds and that there's just so many different pathways and ways to get where you are and how career trajectories can change and how things can happen that you didn't expect. So for the medical students and residents, I'm not sure if we have any on this call, but they may watch the recording. What are some pieces of advice for students or residents that are thinking about it, geriatric emergency medicine, have heard about it, in general, just pieces of advice that you would have for anyone considering the field?
I would say it's a great community. And so it really just means you have to show up, but you just have to keep showing up. And again, I think I tried to apply to the AGEM board a couple times, didn't get elected the first couple times, but there's always ways to stay involved. So you can go on the committees, you can help with the didactics, you can just, volunteer as a student. But that's just a great place to just meet people. And like I said, unlike we've said on this panel, it's a welcoming group. And if you just ask for who can I connect with to explore this idea, I'm sure someone will connect you with someone. who can help guide you, because I think it's probably one of the most rewarding parts of a career in academic emergency medicine is starting to mentor people so you grow the field. And literally, I'm sure for many leaders in geriatric emergency medicine, they really just ended up showing up to the meetings and saying, and then quickly rose to the top because it was such a small group. And I think we are really supportive of one another and want to see each other succeed. And I think we're all aging and crowding is not going away. So this will only magnify in the future as far as the need to have good care for this vulnerable population. And so I think it's got a great trajectory in terms of a career. So that's one motivation, is in terms of there's just going to be growth in terms of emergency medicine departments wanting to have this kind of training and specialty. So I think it's good to get those kind of skills. I get, like Dr. Shaw said, like when she said, it does probably require you to do some kind of 1 to 2 year fellowship, whether it's just clinical or research or advocacy, or education to get, but not necessarily. There are people who are, because those skills are sought after, you can get an academic career faculty position, even if you haven't done training. We just actually we got a paper accepted in AGEM called Cultivating a Career in Geriatric Emergency Medicine. I don't think it's online yet, but maybe, Surya, when it comes online, we can send it, or the link. It just literally got accepted this week, so I don't think the proofs are even sent out. But that basically is just giving you an idea of the different ways you can get involved at every level. So as a student, as a fellow, a resident, as a fellow, as a junior faculty, just the smattering of things. So I'm happy to try to share that with this community in some way, just as a roadmap. And then RAMS has a geriatric emergency medicine roadmap that I think is getting updated, but similarly gives you a different way of thinking about how to get involved. So there's just oodles of opportunities. And then I think, as I mentioned, the sky's the limit. So one of my, even beyond academic emergency medicine, one of my sponsors and mentors is Dr. Charlotte Yeh. And so I connected with her. She won the Gerson Sanders Award last year from AGEM. So she started as an ED physician and then became a department chair, then worked for some kind of like Blue Cross or Blue Shield or some kind of an insurance company, and then became the Northeast CMS leader. So she did Centers for Medicare and Medicaid, and then went to AARP as their medical director, and then basically moved on from that position and now has a consulting career. So I talked to her. I was like, I don't even know how you ended up, like, she was involved in TALA getting passed, with Mitt Romney's Massachusetts healthcare reform, with federal, I think, supplemental insurance, and just like these huge monumental things in a generation of health policy changes. And she basically will tell you, she's like, you as emergency medicine physicians have all the skills to be able to maybe leaders in this field, because you're problem solvers, because you can walk in and basically anyone can throw anything at you and you know how to figure it out. You may not know exactly how to run the budget at that time, but you'll figure it out. And so that ability to think fast, have confidence in yourself that you know that you'll be able to find the resources to get an answer to that question or to tackle it. She said, and she inspired me, you could basically do any of these things because you have that mindset. You're going to just be an action-oriented person, because that's what you do every day in the emergency department. You take a problem and you're not afraid of not necessarily knowing everything right away, but you can get your resources, you know how to address it, and you're really just problem solving all day. So I think it's really, again, more about figuring out as you go along, what do I want to do at this time? And I am a big believer that in the last 4 or 5 years, what has made a difference is getting some coaching. And I highly recommend, if you have coaching opportunities throughout your career, is really to help you continue to align with what you want to do and do it in a healthy way so you don't get burnt out. And I think we do in this field say yes to a lot of different things, but it's more important in your career to know when to say no. It's important to know that this is going to take me away from something else. And so I think coaching is really helpful to say that you can say yes to the 15,000 things that are being asked of you, but it's important to be able to have enough bandwidth to do the thing that you really should be doing that aligns with what you want to do and aligns with your passion on the most. So that's most successful.
I love following Sean because she usually hits all the major points, and I find 1 or 2 little things. If I was going to drill it down, I'd say number 1, find great mentorship, and that's going to include the coach, it'll include the sponsor, and all the other different components that exist. It's probably part of the reason I've been as successful as I've been able to, whether it was Lowell Gerson or others that have really given me a lot of guidance along the way. but great mentorship will help. The beauty nowadays is the person doesn't have to be at your shop, right? I mean, you can be pretty much anywhere. And sure, I have a lot of my mentees here, but I also have a fair number of my mentees that are elsewhere, and vice versa. I've gotten mentorship from people both nationally and locally. So that would be, to me, in some ways, the number one point that I would recommend. The second thing, and we talked about this a little bit already, is find out what you're passionate about. There is no right answer ultimately. I think in the geriatric emergency medicine world, a lot of us started out on the research side, which I think was a conscious decision because that's where the funding was and that's where the interest was, whether it was from Hartford, whether it was from Atlantic Philanthropies, whether it was from the Geriatrics for Specialists initiative. It was really about how do we support research. But we probably 10 years in, we're finally able to get a little bit broader and start talking about clinical operations and clinical care, talking about education and those other components. And so figure that piece out and run with that, at least until you change your mind. Probably the hard thing that people don't like hearing is you need to invest in yourself, whether it's doing that fellowship, whether it's putting in the extra hours. This isn't going to come easy. Yeah, I've had tons of grants and I've been fortunate that way, but most people don't realize I actually applied for my K award 5 times before it finally got funded, which was pretty miserable. And everyone goes up and down. Probably my overall batting average on grants is under 200, and so that means that maybe I'm getting 1 out of 5 funded. And so you have to invest in yourself, regardless of where you are in your career. And then you just have to plain old work hard. It takes those extra hours to really work at this. But the beauty is that work actually pays off. And we see that within the geriatric emergency medicine world, whether it's Katie or Rachel or Sean or whoever it is within our groups, people have done really amazing things and really made a difference, which is why AGEM and all of us that are in geriatric emergency medicine are really held as the standard for what specialties should do in order to build their blank their geriatric blank fields, whether it's geriatric surgery or geriatric endocrinology or whatever the case might be. And it's really been a story of this entire community working together, and being part of it, working hard, and paying it forward is really critical.
I'll just touch on a little bit of all of that as well. So when I was in residency, I didn't really understand what networking is. And so it just sounded like a term that everybody kept saying, like networking, oh, networking. I didn't know how to do it. And I think I'm still trying to figure it out. But I think the most important thing is just showing up. So, like the very first year that I joined GEMS and AGEM, I went to every single monthly meeting, but I probably never spoke or never put myself on video. And I just listened in until I felt comfortable, until I like recognized people. Networking and mentoring, I think some people feel like that's just like cold emailing someone you don't know, and that can be intimidating. And that works for some people if you have a very specific ask and you feel comfortable doing. But I also feel like just showing up, and it takes time. It takes time to meet everybody. It takes time to network and to build these relationships and have people introduce you to other people that can advocate for you. And so I just want to mention that, like, if people feel discouraged that you haven't found a mentor yet, or don't know how to do that yet, it's okay. I went through, I'm not even kidding, probably about 6 mentors before I even got into fellowship, because that was my mentor left after 6 months during my residency. So I had a really hard time getting research up and going during residency, and I felt very discouraged at first. But you have mentors in a lot of different areas, and I think that's really important. So you have more like a career mentor, or you can have more of a research mentor. You may need a research mentor in different areas, and you'll kind of figure out over time like what those relationships are like and what you need from those different people. And there's no harm in asking someone that you truly trust to introduce you to somebody, really make those connections. That how I really got involved in this group is that Dr. Chris Carpenter asked me to go to the gear. I didn't know anything about gear. At the very first 2 months of my fellowship, I flew out to the gear meeting, which is the Geriatric Emergency Research Network, and met all these amazing people. And I really just sat in on their meeting and participated as much as I could. And that really built a lot of relationships and networking. Other thing is to be really flexible, I would say, in terms of in the beginning, I said yes to everything, to every opportunity to collaborate and meet people. And I didn't feel comfortable saying no to anything. Opened up amazing doors and amazing opportunities for me with the Geriatric ED Guidelines group, with the Gear Network projects, with a lot of different things. But I think as you get further along, time is stretched more and more into all realms. I'm still learning the art of saying no and really protecting your time and really protecting your interest of focusing on what you know is going to keep advancing you to where you want to go. And so those are kind of the additional things that I've learned over the last few years.
Thank you guys so much. I 100% agree with the advice of mentorship early on. For me, 100%, that was actually how I became more involved in AGEM. My residency didn't have SAEM membership. And so my very first mentor within AGEM was Sean Liu, actually. And I just can attest 100% to how important just people within the field who have come before you, how much that can help pave the way for career trajectory within an organization or beyond. So we actually have one submitted question prior at the time of registration. So I'm going to say something, but the question that we had was, do you have recommendations for specific webinars, workshops, or other learning opportunities for EM researchers who are interested in becoming involved in geriatric emergency medicine research? Recommendations for specific webinars or workshops or learning opportunities for EM researchers who want to become more involved in geriatric EM research.
Maybe I'll start off and then Rachel and Sean can add to this. I would argue that you've got two different buckets that you need to be learning in. One is going to be the pure research side, and that's just kind of standard research methods, research approaches, and that component. The other piece that's equally important to learn is really what is geriatric emergency medicine all about, right? This is, I would argue, is a somewhat separate body of knowledge that we need to think about. You're not treating your 20-year-old the same way you're treating your 70-year-old. And that's it. You can learn that in a lot of different ways. If you're in a place that has a geriatric EM fellowship or you have a geriatric EM group there, then you could work with them and develop those skills and strengthen that content area. Or you could do what I had to do, which is I actually made really close connections with the geriatrics folks at my institution, and I worked with them to learn the geriatrics component, and I filtered it through our EM world, right? So I'm not going to stand there and sit there and do a 3-hour eval for cognitive status. But on the other hand, I'll figure out how to do it in 3 minutes. I'm not going to do some of the things that they would do in a geriatrics clinic, but think about how to filter it through what I need. And then from that, you can figure out what are the pressing questions? What are the things you are interested in answering? So I would argue that the way to do it is going to both of those groups. Where you go from that to get it, there's a ton of different opportunities. I'm a little more old school. I would argue that a fellowship's great for the research side. Don't necessarily need that. A degree is great. Don't necessarily need that. SAEM has the armed training program, which is a good way to do some initial training if you're just trying to figure it out. But from the research side, I would argue the more structured and rigorous you can go, the more likely you will be to succeed. On the geriatric EM side, I think there's a lot of different components you can go to, whether it's stuff AGEM puts on, whether it's stuff that comes to the geriatric EM section at ASAP, as well as there are a number of podcasts and other journals and things that you can read to and pay attention to. I'll stop and then let Rachel and Sean take that.
So I just joined, when I joined different societies, I signed up for their listserv. And for AGS, American Geriatric Society, for example, I'm on like their EM specialty interest listserv. And so you get emails of when their monthly meetings are, when the webinars are. And I just try to go to as many conferences as possible and really focus just on the content that I will find like is most applicable to me. So I'll go to AGS, particularly if it's virtual. I'll go to ASAP, SAM, GSA. For more specific topics, like I'm interested in impairment, I joined the NIDIS, which is like a delirium network, and did their boot camp. I did the Butler Williams Scholar boot camp through the NIA. So there's a lot of different boot camps. And then I really just are my local resources. So I do sign up for all the webinars and talks for like research specific things through our clinical and translational science center. I also like with our geriatrics department on if they have journal club, or if they have our center for aging research, if they're doing webinars, which they do monthly webinars, the palliative medicine, and just really try to get as emails as possible on our filter from there. But I think really trying to hone in, and then just doing the listers at the start. There's so many different organizations that have just amazing, like JEDC, but ClinStar is one specifically for research that puts amazing webinars on, and also has sessions that you can talk to program officers worship as well.
Yeah, I think there are a wealth of opportunities. JEDC we just did a webinar last month, and I put the link in the chat that if it kind of depends on what your level of experience is already. So if you already have an MPH or know how to do research, then the resources that are out there you probably want to focus on how to do geriatric specific research. There's certain stats or certain ways to like think about, you have to include mortality much more than you have to think about in pediatrics. If you are a med student, then I would really recommend, at the end of the day, after having taken a ton of research classes in my training, one of my mentors said, at the end, you still just have to do the project, and you will have to have a good mentor that actually can walk you through this. Because there's a theoretical, you can like take a million classes, but until you actually apply it, it's like med school and residency. Until you can read all the books and you can be book smart, but until you can actually translate that into the bedside and take care of patients. So you learn, obviously we learned how to be emergency medicine doctors through our residency, not necessarily just through reading, although both are important. So it's important to sort of have both, is to, one, try to find somebody that, either has a project going and you can say, I can help you with this, I can help you with this part of it, or how can I be involved, and then learn through doing. And then also these other options these other formal opportunities, either through lectures or through formal training, like an MPH, like that both Manish and Rachel mentioned, are really important. But I really think that much of what I learned was also just bumbling through and making mistakes and being like, oh, okay, I understand this now. Like why logistic regression is the way, like why you have to do this. And so I think that's why it's important to have some kind of fellowship where somebody's going to guide you through that, and somebody basically wants to own your learning process as far as doing research, who's invested in meeting with you every week or every other week to really walk you through a project. So another plug for some kind of, fellowship.
Thank you all so much. We actually have one open question in the chat that we can start with, and then we can see if anyone else who's here has any other questions. Thank you so much for your question. Your question was, can you tell us, for the panel, how do you describe geriatric emergency medicine to your colleagues and your family?
I asked this because I made my family listen to some of this, and my partner, because it's so hard sometimes to tell your colleagues and your family, like, this is my interest. So I would love to hear what you all have to say.
Well, I'll tell you, I'm still trying to explain emergency medicine to many of my family members. So, I've been doing this for almost, 25 years. So I haven't been terribly successful. So take this for what it's worth. The way I really explain it, it's emergency medicine that focuses on the issues that are unique to individuals as we age. And I usually intend to use dementia as the example, or because that's something people are generally familiar with. So I don't know. That's basically how I do it.
I like that. Yeah, but generally how to improve the care of geriatric emergency medicine patients. It's much kind of what I think of it as.
Yeah, I give a lot of anecdotes. So I try to like have people visualize a patient that's having like some type of adverse outcome that's unique to older adults in the ER. So I'll say my father-in-law, for instance, he keeps coming into the ER conveniently due to his Parkinson's. And so I'll mention, that he can't walk into the ER, that someone is going to have to help him if he didn't bring his cane or his roller walker that's causing his falls. And then he has medications that he has to take regularly. Like he cannot miss any of his Parkinson's medications, even while he's in the ER. And so he carries them in his pocket. Can he get them out of his pocket? Did they take his clothes? I try to give a lot of anecdotes that are specific to geriatric syndromes, and that's helpful. But honestly, especially in the research realm, my husband just picks out these acronyms and if I hear the K23 one more time, or if I hear 32 one more time, 'cause a lot of acronyms and not nobody knows what those mean. Even my colleagues are like, difference between a K or an R or a T, is that good? It's down the alpha? And so the research specific stuff I think is a lot harder to explain than geriatric EM.
Thanks. Do we have any other questions for anyone who's here?
I have a question, actually a question for Manish as a chair. What would you tell people either graduating from residency or from fellowship, ideally, if you wanted to have a career in research in geriatric emergency medicine, what would be an ideal amount of time clinically in terms of investing in yourself, trying to give yourself as much ability to succeed? And if you wanted to go down the GEMSTAR-K route, what would you recommend for FTE in terms of clinical time?
It's a really tough question, right? So it's one that's debated and discussed a lot is, well, how much time should I be working clinically? And, my answer to it is actually, it really depends on the place you're looking at. So if you're looking at a place where your shifts are incredibly difficult and exhausting, and that's going to play into the factor because you're probably not going to want as many shifts because that really impacts your following day. You're going to have to think, if you're going to go to a place, some places pay really well, but then they expect you to work more shifts. And so then the question then becomes, well, if you want that salary, you're going to have to think about it because maybe you're going to be asked to work more shifts. And so in my mind, it's really a conversation you need to have with that chair because some places will say, hey, we have all these added resources. Yeah, you might have to work a few more shifts, but we've got people that can help, put the grant together, do this, do that, and do the other thing for you. And some places may say, yeah, we don't have any of that, and we'll protect you a ton. And so I don't think there's a specific answer to that. And I think it really becomes a conversation. I know we've brought a few people on here, and the conversations usually pretty much ended up in the same place, which is one part, how much support we can give the individual to get their stuff done. One part, how much time do we free up for that individual? And then one part, how much training and experience and stuff do they have? If they've done a fellowship, if they've already gotten going, they're going to be in a little bit different place than someone that just comes out of fellowship and is still trying to figure out what area they want to do research in. So it's kind of a non-answer, but I think the reality is that you have to have a conversation and figure out what's right because every institution also has very different strains and very different pressures in terms of what they can make happen for someone.
Awesome. Thank you.
Thank you guys so much. We're almost at the top of the hour. Thank you so much, Dr. Sean Liu, Dr. Manish Shah, Dr. Rachel Skanes, and thank you so much, Dr. Katie Buck, and everyone else for joining us here or who will be watching this recording later. These are just to remind you guys, if you want to get more involved in AGEM, you can join SAEM.org/AGEM. It's a free academy of SAEM. You can join AGEM via the Academy's link on your SAEM account. There are subcommittees within AGEM, and you can join us at SAEM 2025 in Philadelphia coming up. And we have a Twitter page, an Instagram page. And if you have more questions, you can reach out to the current president, Dr. Katie Buck, or myself, the secretary. But thank you guys so much again for joining us.
Thank you, everybody, for joining, and thank you to our wonderful panelists. I learned a lot.
Thank you, guys. And thanks, Melissa and Dawood, for being our wonderful staff. Hope everyone has a great night.